Welcome and thank you for joining us today. I'm here with my colleague Jake Pitts. I'm Russell Anderson and we are Equity, Diversity, and Inclusion Officers here at University Health. We have an important guest today. We'll let him introduce himself shortly, but I wanted to remind everyone of what our purpose today is with the panel, and we have three reasons today. The first is to increase our awareness around organ donation. The second is to soften perceptions towards organ donation. And lastly, we're going to talk about ways to enhance our understanding and the power of organ donation. So with that, I'd like to take a pleasure to introduce you to Dr. Dustin Neel. Dr. Neel, would you take a second and introduce yourself, please?
Good morning. My name is Dustin Neel. I'm the Trauma Medical Director at University Health Truman Medical Center and the Director of the Surgical ICU at University Health Truman Medical Center.
Before we get started, could you just briefly tell us why organ donation is important to you?
Organ donation is extremely important to me. Unfortunately, in our society, we have a lot of senseless violence, a lot of bad injuries, a lot of unpredicted trauma to people who are just living their normal life. And organ donation, unfortunately, can be the only silver lining in some of this senseless violence. For those people who are unable to survive their injury, they have the ability to give patients a second chance. Some of those patients who are dying from diseases, from long-standing illnesses like dialysis, diabetes, heart disease, liver disease. These patients, these heroes that we have that are willing to donate their last organs to these people have the ability to save their lives and be heroes forever.
I'd love for you to take a moment to expand on that because today's content is heavily addressed toward our community. So I'd love for you to speak on organ donation as it pertains to the ability to influence someone's quality of life.
Dialysis is a 3 to 4 times a week process, requiring 3 to 4 hours a visit. It requires transportation to and from. Those patients are basically connected at the hip to these facilities. They have to get it or they can't live. One organ donor has the potential to save 2 patients from dialysis, 3 trips a year, 3 trips a week, 52 weeks a year for the rest of their life. And so that is a life-altering opportunity for patients to have if they're able to accept an organ from a potential donor.
Thank you for that, Dr. Neel. There is immense power in donating for multiple reasons, and it's a value that we can't even begin to describe within the community. Going forward, could you please explain to us what you're looking forward to the most out of this panel today?
Absolutely. This panel is very important to me. There's a significant number of misconceptions about organ donation amongst the community and the nation at large. The goal of this panel is to diffuse some of those misconceptions and some of those myths so that people can understand the truth about organ donation.
Thank you very much, Dr. Neel. Thank you again for your time and being able to set the stage for this really, really dynamic panel that we have slated today. And ladies and gentlemen, without further ado, we want to go ahead and take it to our conversation with our esteemed panelists.
Welcome, everyone, and thank you for joining this panel today. My name is Russell Anderson. I'm the Equity, Diversity, and Inclusion Officer for Administrative Departments here at University Health. And my co-moderator for today is my colleague, Jake Pitts, Equity, Diversity, and Inclusion Officer for Clinical Departments. Quickly, the purpose of our time together today is threefold. One is to increase our awareness of organ donation. 2, to soften perceptions around organ donation. And lastly, to enhance our understanding of the power of organ donation. It's my pleasure to introduce our esteemed panelists today. We'll start alphabetically with Dr. Harry Wilkins. He's the President and CEO of Gift of Hope Organ and Tissue Donor Networks. Prior to his current role, Dr. Wilkins practiced acute care surgery with the Quincy Medical Group in Quincy, Illinois. He has served as the Administrative Medical Director for the Midwest Transplant Network and has been actively involved in the Health Resources Services Administration's efforts at improving organ donation and transplantation rights. Dr. Wilkins completed medical school at Northwestern University's Feinberg School of Medicine and holds a Master's of Science in Healthcare Management degree from Harvard School of Public Health. Welcome. Next is Jack Lynch. He's the Senior Advisor for Gift of Hope Organ and Tissue Transplant. He directly supports the president and Gift of Hope's senior leadership team on community relations, minority relations, and organ, eye, and tissue donation awareness and education. Mr. Lynch attended City Colleges of Chicago and Chicago State University and participated in the pre-med program at Meharry Medical College in Nashville, Tennessee. Welcome, Mr. Lynch.
Thank you.
And lastly, Dr. Michael Moncure. He's a member of University Health's Department of Surgery and a professor of surgery at University of Missouri, Kansas City, and the Paul Coffey Endowed Chair of Surgery for Education. Dr. Moncure has special interest in violence prevention, surgical education, shock, sepsis, and surgical outcomes, as well as appropriate and efficient surgical and medical billing and capture of charges. Dr. Moncure completed medical school at the University of Washington School of Medicine. Welcome, and thank you all for taking the time out of your busy schedule to be here. We really appreciate it. I'll now turn the floor over to Jake to get the discussion started.
Thank you for that introduction, Russell. And yes, thank you, our distinguished panelists, for taking this time together. Really looking forward to this conversation. Dr. Moncure, I'd like to start with you and delivering this question to you. I'd love for you to just open our conversation with naming a common scenario in which you've encountered the urgent need for organ replacement.
So, Jake, thank you again for the invitation to this panel. And thank you, Russell, for the introduction. I would say that as an African-American member of this United States, I've got relatives who have had medical problems greatly. I had a cousin who was my age, a contemporary, who actually needed a liver and needed it expeditiously. All my family, for the most part, are in California. She was actually a part of Kaiser and actually had to be evaluated and transplanted in Jacksonville, Florida, through Mayo. That's who they contracted with. But I was able to kind of guide her through that whole system. And luckily, she had the resources to actually to receive a liver and has had an excellent life. But up until that point, I mean, her quality of life was horrible. Also had a cousin with renal failure that actually did not get a kidney because he had medical problems that precluded that. And I watched the difference between those two scenarios, and it was stark. Renal failure is something that's pretty common in our unrepresented communities, and it's something that if you receive the gift of a kidney, it adds 10 years to your life. Not to mention exceptional enhancement in quality of life from the standpoint that you're not spending 3 to 4 days a week for 4 hours in a dialysis center. So this is something real, and I've also seen patients and family and friends who've needed heart and lung transplants, which again, these are things that you're not able to live and exist in any kind of reasonable fashion without that actually occurring.
Thank you, Dr. Moncure. This next question is directed to Mr. Lynch. Mr. Lynch, what data would you like us to be aware of that helps us understand the power of organ donation?
So let me approach that in two phases. One will deal with what normally is suggested throughout my 30 plus years involved in this area of healthcare. It always ends up in the dismal position that folks of color are least likely not only to donate, but to make their way to the list. And all of those things continue to point to the fact that I don't think that they're asking the right questions when putting together the data questions. Mm-hmm. So what we did in Illinois and have been successful at is that we accumulated and started our own data. In fact, we used the data as a catalyst, if you will. So we asked a different series of questions. Number one, dealing with the volume of trauma in a particular trauma program. Who are those trauma patients? What are the zip codes from our metropolitan area that they represent? And why have we discounted the value of potential donation, particularly in lieu of the fact that it is that and those zip codes that represent all of the challenges that we clearly need to address. So we formulated a different series of touch points and data points that gave us the conclusion that if in fact we encompass the aforementioned things that I talked about, then we could come up with a scenario to breach that standard acceptance and also the way in which we as healthcare professionals look at it. I can tell you that it is effective. It works when you pay attention to the zip codes and you bring a language and you bring individuals who can speak to the major concerns. I say without apology to this group, African Americans are no less willing to donate than any other ethnic group when we approach it in the right vernacular and demeanor. So those touch points that I aforementioned earlier on, they clearly pointed to a point when Gift of Hope, which is no less than the third largest OPO in the country, meaning we do a fair amount of donors. There have been periods and times when 3 out of 4 of our donors have been African American for a number of years. So I think that utilizing data that's going to give you an opportunity to involve the communities and touch them where they are. Trust me when I say it works.
Wow. Wow. Thank you, Mr. Lynch. So with two of our goals being to soften perceptions and enhance understanding around organ donation, we thought it would be important to go around and dispel some of the myths regarding organ donation. So to each of you, Russell and I are going to give you a few of the myths that are out there about organ donation. We'd love to hear your response to these. So Dr. Wilkins, starting with you, I'm gonna just name this myth, and I'd love for you to address it. If I agree to donate my organs, the hospital won't work as hard to save my life.
Yeah, so first of all, I'd like to say that I've heard that a number of times. And I think I'm looking at my colleague, Dr. Moncure, and I, who were fellows together, and we have dedicated our lives pretty much to saving lives, anyone who's brought in. And I can tell you, I've had this conversation with him and other colleagues, there has not been a single time when somebody comes into my emergency room injured and dying where I have checked insurance, background, criminal record, political association, religious beliefs, station in life. It does not matter. My number one goal is to save the life of that individual in front of me. And I'll go one step further. If I fail, I take that as a personal failure. So first and foremost, and I'm going to put a punctuation on that with my second story. First and foremost, I want to save the life of the individual in front of me, because the truth of the matter is there's over 100,000 people on the waiting list. None of them are right there in front of me to ignore. So first and foremost, as a physician, my number one job is to save their lives. So there is absolutely no validity to that myth. The second thing about that is, though, is that if I am not successful, I take that as a personal failure. And so even in my role now as CEO of an organ procurement organization, I can tell you that up to a year and a half ago when I was at the bedside, there have been times when the last thing on my mind is organ donation. So I don't know how else I can put that, but every colleague that I know has spent 20 or 30 years learning the craft of saving someone, not in the business of, oh, this is an opportunity to get organs. It just is not the case. I see Dr. Moncure shaking his head, yes, so I'm taking that as agreement.
That's powerful. And full disclosure, I know people close to myself that hold that view. I'm not going to put it on my driver's license because if I get in a wreck, I'm in trouble. And that's powerful to hear. Thank you. Next question is for Mr. Lynch. We're dealing with the thing around people's belief systems and faiths. Organ donation is not accepted in most belief systems and faiths. What do you think about that?
I took that question and turned it upside down, sideways to get a better view of it multiple times. I'm going to steal a part of Dr. Wilkins' comment. I'm yet to ever, in the 34 years and several thousand cases, I'm yet to have ever encountered that more than twice in terms of interacting with donor families. Now, in public settings, when I've been out and we do the Q&A after presentations, I've heard that. But I can tell you that I'm going to continue to go back to the message of talking about the things that drive the paradigm. And one of the significant things is that mastering the talent, as the two positions have indicated, but mastering the talent of talking with potential donor families seems to be one of the most lacking features out there. I think we as healthcare professionals potentially have a potential to come out and to throw data to families in hopes that they gather that. They bring to the table any number of other challenges that we need to be mindful of. But I think I don't apologize, and I often have this conversation with Dr. Wilkins. The question that was posed probably isn't real, and I would offer that I would continue to push that mastering the talent of talking with families at such an acute moment lends itself to removing the barriers that we thought were there because of race and ethnicity.
Yeah. Thank you for that perspective.
I'm on a panel with two brilliant people, and I think that a lot of what has been said thus far is extremely important. One of the things that Jack mentioned and Dr. Wilkins mentioned as well, that a lot of things that impede individuals from saying yes to organ donation is trust. And so that if you look at the data, people that decline organ donation, families that decline, it's because of trust. And if you're not human with them, if you don't look like you're fully invested in their survival and the best possible outcome for them, you're not being transparent, these are things that are going to not bode well. And we have situations, and I've throughout this pandemic has been an extremely important example, and I've done a lot of things to try to help underrepresented communities because there's a lack of trust in the medical health system, and we've got to be transparent and tell them why you should be able to trust them, and you got to show that in your actions as well. Sure. And once you deter from that, we're not going to go well.
Absolutely. Certainly. Thank you all for advocating for healthcare professionals to build trust, and also for our community being able to approach our providers with trust. So, Dr. Moncure, keeping our conversation with you, many in our community face these myths, and they consider these myths, and as our community has conversations about organ donation, here's another one that I'd love for you to respond to. There are enough organs for those who need them.
There could be nothing further than from the truth in that statement. Simply from the standpoint that you heard Dr. Wilkins mention before, on any given day, there are well over 100,000 individuals that are in need of organs and need of a life-saving transplant. And when we look at the clock in the day, I mean, there's at least 20 people added to the list, and it just continues to mount. We probably generate 30 to 40,000 organs per year. And so if you do the math, there's no way we catch up with what we're doing currently. And so that is a complete myth. And it also, I beg to differ with individuals that say that, simply because our underrepresented communities are probably even more in need.
I'd like to go ahead, Doc.
I spent quite a bit of time in Kansas City, and I always try to put this in perspective. So the number of people waiting on an organ, it's Arrowhead and Kaufman combined. Arrowhead and Kaufman combined. That's a lot of people. And Dr. Moncure just said, we just had a record-breaking year where the entire United States produced 40,000 organs, and we're adding 20 a day. So it's simple math. There's just
let me attempt to bring it home even more so, Doctor. It is not in our required activity to screen phone calls. On a weekly basis, if I don't get 6 calls asking how to get on the list and how can they get an organ from people who have just found themselves in organ failure, I mean, they find their way to us at Gift of Hope, and specifically to me. And I'm wondering how these folks find me in the manner in which they do. So Doctor was right when he pointed out that nothing could be further from the truth. On a daily basis, people are approaching me about how to get a transplant.
I think that's a consensus, Jake.
And people are dying daily as well as a result of not getting those transplants.
And that's I'm kind of speechless at the need and just that deficit that runs every year. I would never have known at all.
Part of the, I'd like to add to that, is that if in fact that scenario grows legs and is able to be discussed during policy, then the disenfranchised get even more disenfranchised because it's believed that people are trying hard enough to make their way through the maze and get on a list. So I bristle up strongly when I hear that. It doesn't matter the arena, because it's only going to hurt those who need our support the most. That's my point.
I will tell you that if you ever take the and I know Jack does this quite a bit, is every now and then just go around and you look in certain communities where there's more dialysis centers than there are grocery stores. Walk into one of those dialysis centers, ask any one of those that are hooked up to a dialysis machine if there's enough organs to go around, and ask them how long they've been waiting, and you'll get a very different answer. There are simply not enough organs to go around.
No doubt.
So if you see a dialysis center in your community, that's not a good sign at all. I live in a rural community, and we have one in the middle of town. It sounds like an issue that is rural and urban.
Well, I will tell you that organ failure, yes, it does affect certain populations disproportionately, but organ failure, heart, liver, lung, it is indiscriminate to class, race, social structures. So yeah, it's not a good sign to have that. So if you see them in a rural community, that's because there's a need in the rural community.
Doctor, if I may, I'm home sitting in my dining room / wine room, and I'm looking out the window, and there are 3 dialysis centers within eye view of me, right here in the south suburbs of Chicago. I get really irritated and challenged, but I know that there's work to do even amongst us as healthcare professionals.
And as Jack Lynch would say, third time, there are simply not enough organs.
Period. Yes.
Thank you. Well, I'm sure that point will probably raise itself again as we continue through our conversation. I don't see
Absolutely.
it coming back up again. Dr. Wilkins, this one's for you to take. Someone comes in and their concern is organ donation drastically affects funeral planning, whether I have an open or closed casket.
Sure. So I think one of the things that morticians are very good at their craft And one of the things you have to understand is with the organ donation and with tissue, eye and bone donation, you have to understand, and I've been in this business enough to know, this is a very sacred thing. And the people who are in this work honor that gift. And so those gifts are procured. We use the word procure. Those are procured in a way specifically to preserve the ability to have an open or closed funeral. People choose on their own to have cremation, open casket, closed casket. All of those options are preserved in the manner that we procure organs, in the manner that we procure corneas, in the manner that we procure skin and bone. And so that is simply not the case. We have had numbers of people who have donated all of their organs, their eyes, skin, and bone, and have had open casket funerals. So again, it's just one of those myths that's perpetuated, and it does not preclude an open casket funeral should you choose that route.
Sure.
Wow, thank you. That was very insightful for myself, for sure, to know that you could give these gifts and still have the kind of service that you would desire. Yeah, that's powerful.
Yeah, and I will tell you, as my years as a trauma surgeon, we've seen people that have fallen out of buildings, been shot multiple times, they're stabbed, they're in various, you see a lot as a trauma surgeon. And even if they're not donated, if once they've died, we have the family step out and we'll prep them, clean them up, put a cover over them so that they can be presentable for the family to see. And I'm sure Dr. Moncure has seen that before. I think it's overseen. And again, I always like to bring the human part of the physician to this. Remember, we as physicians are hugely invested in that person, no matter how short of a time we're involved with them. It comes down to what Dr. Moncure says. It's that trust and respect of that patient that you're caring for. And so even if they're not donated, if they're not an organ donor, we still want to make that person presentable to the family, because this is also about the family. It is no less the case with organ donation. And so that is preserved in the aspect of getting organs and skin and bone and corneas. All those things are preserved.
Wow.
I'd like to point to, if I may quickly, along those same lines. We go until we're at the least common denominator with a potential donor family. When Doctor talked about making patients presentable so families can view them, it put me in mind of the hundreds of funerals of donors that we've gone to, and just go to show your support to the family so they didn't view the process as we are carpetbaggers or anything negative. And I cannot tell you the number of times that I've walked in along with other Gift of Hope employees, spotted by members of the family that we've spoken with during that traumatic moment, and had caskets reopened. Families wanted to have another viewing so that people could see that there is no disfigurement of bodies. That's why our numbers for African Americans went up, because that's, that's a big factor to wonder how the body was going to look. And so when we segmented out the segments that's going to be the most unfortunate in the position to be donors, they're part of our army versus on the other side.
Certainly. Thank you for adding that, Mr. Lynch. Dr. Moncure, here's another myth that exists in our community. I'd love for you to speak to our community about this myth. And the statement is, my health is not good enough to be an organ donor.
I can tell you that we've evaluated numbers of individuals. My Dr. Wilkins and myself were medical directors of Midwest Transplant Network. And prior to us kind of onboarding and creating a critical care committee, there are a lot of individuals that probably could have been organ donors, but the expertise was not accepted in regards to critical care management of those patients to get them ready for potential organ donation and giving the gift organs for transplantation. And so there was probably a difference in our perception and our management back in 2003, 2004. But since then, we've been able to make good on a lot of situations that may have been marginal or what have you. The organ procurement organization are experts in regards to screening which organs can be transplanted, which are donated, and which can't. I would say that there are very few instances where individuals are too unhealthy to actually donate, and I would leave it up to experts. I tell anyone that asks me, say yes. If that's in your heart, say yes on your card. And I think it's really something that's excellent to applaud our communities in Kansas and Missouri, because over 85% of individuals are first person authorized donors. Or they've gone to a motor vehicle department and they said yes. That means that you can almost assume that most people are going to donate. And I tell them, do that. If that's in your heart, let the organ procurement organization sort it out. And I guarantee you there are most likely a number of things that you can help that would save someone's life.
That's uplifting. That there's a role that we all play, and what's really important is just to let that decision be made and to say yes. Thank you.
In particular, Russell and Jake, you guys are younger than us. Your generation is really good about this. They are really not selfish, and they look at these potential situations as the right thing to do. And I noticed that in my kids as well. And I just applaud you all.
Yeah, agreed.
Can I add one point about the suitability? Most people think that they're less healthy than they actually are. And what we have to keep in mind is if someone's waiting on a life-saving organs, their organs have failed. So even if your organ is 100%, it's better than somebody that's on the wait list. You may think that you're too old. Back 20 years ago, 50, 60 was the upper limit. We've taken organs from people in their 80s. And so we're constantly making advances in organ donation. And as we know, as people tend to take care of their health, you may have a failing heart, you may have a failing liver, but your kidneys may be okay. You may be in kidney failure, but your liver may be okay. So again, as Dr. Montier said, I would not self-select out for being suitable. We're making so many advances that we want to really have that ability to be evaluated. So I wouldn't select yourself out. Like Dr. Montier says, if it feels in your heart to donate, make yourself a donor and then let the professionals evaluate you should you get to that unfortunate circumstances. I would not rule that out.
Doctor, you put me in mind of one of my last cases that I did. I was in with a family and we were discussing various organs, and it came to liver, and everyone started laughing. And I asked why. They said, well, he drank breakfast, lunch, and dinner. I said, I really want that liver then, because it's huge. And the fact is that we did recover that liver. That liver's in an individual now.
Yeah.
It's just, again, that talent of talking with families. I cannot tell you how often we come out of the room and it is a total different flavor prior to talking with them, meeting them where they are and staying there with them. As the other physician mentioned, for them to trust you and to have good communication skills, it has driven our numbers. And I think we dispel that myth about African Americans' willingness to donate.
You're on a good point, Mr. Lynch, and the next question is to you. But before I move on, I just want to say, Dr. Montier, thank you for thanking our generation. I was trying to make sure I have, and I just wanted to prove right there.
There you go.
That I had. So I'll accept your graciousness. Mr. Lynch, kind of along the lines that you were talking about with underrepresented populations, One that we hear is that the privileged and majority populations make it to the top of the donor list.
Yes, in fact, I do hear that. And I've used any number of approaches. One of them is to talk about the percentages of where the vast majority of organs that are recovered are coming from. And people do just what you just did. They shake their hands. Oh, okay. They're here. But I will tell you that I don't consider that a huge problem. I consider that a safe harbor that people try to duck into when I'm working with a potential donor family. I just don't believe that I give it a lot of legs. I have a very direct answer and I respond to them. And it seems to be that when they're grasping for those types of straws, just don't give it legs. There's a way of communicating whereby people recognize that they raise something, you're going to be respectful in answering it, but it really doesn't have legs. And that's one of those questions.
I'd say that is the 100% correct. And the system that actually makes decisions in regards to who receives organs or whose list is honored or what have you. When an organ comes up for potential transplantation, it is about as objective a system as you can get. And the bottom line is that you need to be in a center or to be on someone's list that's going to be able to perform that transplantation. And you need to abide by whatever rules they have in regards to making sure that you're considered for organ transplantation. It may not, Dr. Wilkins and I aren't transplant surgeons, so we don't have as much problem with the system, but the system is built from the standpoint to be as fair as possible and to provide that organ to the individuals that need it the most. And oftentimes we at Midwest Transplant Network, we're probably hit 400 organs this last year. And out of those 400 organs, a lot of those organs go to other areas. It's not necessarily Kansas City or Leawood or Overland Park. It's going to be where people need those organs.
Certainly.
Things that have happened that probably deflected some of the trust that the community has, such as our Apple CEO getting it. But he used his knowledge from the standpoint, he found that the center in Memphis was a very aggressive system and that they would transplant for his particular disorder and that they had a lot of organs that were coming there that other places had rejected. So and so you can do that.
Yeah.
It's on the list. It's not going to go to the richest person or whatever. It's going to be to the person that needs it the most at that time.
Great. And thank you for taking a moment to bring up the wait list and the process. You were alluding to that. We'll zoom in on that a little bit more after this question, Dr. Moncure. I wanted to first thank you all for addressing these myths that are out there in our community. Let's get back to a few questions that we'd like to provide you all, give our community more information. Dr. Moncure, wanted to give you this question. How does organ donation directly impact disparities in chronic conditions experienced by minority populations? We've alluded to this in our conversation thus far. Wanted to zoom in on the impact that organ donation can have on chronic conditions experienced by our minority populations.
The individuals on the list, when you look at the 100,000 people there, over 100,000 people that are on the list, a lot of those individuals are on because of renal failure. Renal failure is something that there are disparities in regards to individuals with renal failure that are underrepresented minorities. And so you look at, if we had 10 people that were in need of renal transplant, if you were to transplant 5 of them, you can almost say that those 5 individuals are going to have such a much better quality of life. They're going to live longer. They're going to be able to live normal lives and and participate in normal activities. Whereas those other individuals are going to live shorter lives, they're going to live less quality of life, and they're going to be looking at where they can be dialyzed or wherever they go. And they're going to be basically tied to a chair, roughly 3 to 4 times a week. So that in itself, I mean, if you look at that, and it's something that increases the quality of life. The previous administration, did have the knowledge to know that they needed to do something different in regards to kidneys, and so there was an effort to kind of increase that as a way of decreasing health costs. That's another thing that comes along with the renal transplant. You would think that this costly operation might drive up the cost of medicine. It actually reduces it significantly. It costs a lot to be dialyzed 3 to 4 times a week, and it costs a lot less to get drugs that will maintain your kidney, if you were to get a successful transplant.
Let's circle back to the wait list. Dr. Wilkins, help us understand the criteria and the process surrounding the transplant wait list.
Right. So organ procurement organizations' primary goal is to obtain organs for individuals. Those individuals needing organs are maintained on a wait list that's held by their specific transplant centers. Now, there's lots of different factors that go into placing someone on a list. First of all, you have to know that you're sick. So typically your primary care physician will indicate that you're going into some sort of some sort of organ failure, and then they refer you to a specialist. So if you just start there, and Mr. Lynch alluded to this earlier, one of the issues that we have in underserved populations is access to care. I think University Health understands as well. If you don't have a primary care physician, you're much less likely to have a primary care provider to then, number one, recognize you have impending failure or failure, and then refer you to that specialist to get you listed. So as Mr. Lynch alluded to earlier in his comments, is he will get a call sometimes trying to find out how can I get listed. What that points to is the lack of access to primary care services to have someone who can advocate for you to get on the list, first of all. So that's that first entry point. Once you get on the wait list, then there's lots of socioeconomic factors that go into finding out should you qualify for an organ. Socioeconomic factors such as if you get this organ, who is your support system around you that can take care of that? And that becomes the second step of disparity. You may be deemed by the transplant center to not be a qualified recipient candidate because you don't have the traditional support system around you. And so this is why we have to open up those evaluation systems to provide that equity to make sure that those individuals who need an organ get adequately listed and are supported to get that transplant and then the organ itself. So I know that's a little bit of a roundabout way, but this is how there's health disparities and then there's health care disparities. This is one way that health care disparities will prevent you from getting listed. But health disparities, as Dr. Moncure alluded to, communities of color are inordinately affected through atherosclerotic heart disease, high blood pressure, diabetes, to then be more propensity to have organ failure. So it is a domino effect.
Yeah. Wow.
It is not only a domino effect, but Dr. Wilkins, you brought up something that was somewhat of a sore point for me. I won't name the center here in Chicago, but there was a center that, as Dr. Wilkins alluded to, the transplant surgeon and the clinics that all these patients need to attend, you can get knocked off the list. You can be looked upon as not a very favorable patient that's going to take care of that organ if in fact they got one. And that seemed to have been the tenor. And I sat in on one of those meetings and I got very irritated. I said, well, the vast majority of patients you're talking about, they travel on 3 different forms of transportation to get down here to your clinic. Take the clinic to them and put it in the community. This was 10, 12 years ago. This particular center did just that. I should have told them, just give me more money. But they did just that. They had a satellite clinic right in the zip codes where it's needed, where they're evaluating the patients the same way they were evaluating down at the major hospital. So I think you have to challenge that people mean no ill, but if they don't know, they don't know. And we try to make it our business to be on point to suggest things that are going to be helpful to extend life of everyone.
And Dr. Moncure alluded to the previous administration back in July of 2019 understanding these factors and have embarked upon what's called the ECTLC. It's the End-Stage Renal Disease Treatment Choices Learning Collaborative that addresses these aspects that impact how you get people on the wait list, how they're evaluated, and how they're supported afterwards, looking at those zip codes, and then trying to match those resources with those needs. That's a sort of a long-winded explanation for that wait list. But to the point about somebody says, well, the rich get transplanted, they just have more resources, which begins with primary care. So it's not a completely untrue myth, but people with more resources have fewer healthcare disparities. And so it's a trickle down.
Correct. Yeah. Thank you for that.
Also point out something that was mentioned by Dr. Wilkins, is that if you're a primary care physician and you're not aware, or you have implicit biases in regards to, oh, this is Joe, I've been seeing him for 20 years, he's not going to take care of the kidney. I mean, if I'm the transplant nephrologist and I have that perception, or if I mean, we have data that shows that cardiac cath and cardiac operations and some of these high-end items that are necessary for management of someone in survival, sometimes our implicit biases get in the way.
Sure.
It may be that we don't do everything we can. I don't think anyone that's going to be at the bedside and say, this person doesn't deserve dialysis, that's going to happen. But how about renal transplant? How about kidney transplant? How about some of the other more advanced technologies that are necessary?
Sure, absolutely.
Gentlemen, I'm curious from each of you, what next steps would you encourage the community to take?
I would like to start that. So I would think awareness and education is number one. So we've talked about a lot of things on this very short call, and all of them are very important. Implicit bias, health disparities, health care disparities, access to care, advocating for health, and then understanding the socioeconomic determinants of health that then can impact, for this purpose of this discussion, transplant. So I believe programs like this, and thank you very much for putting it on, just increasing awareness is the way to combat myths, is to make sure you're getting your information from reliable sources. So that I will pass it on to Dr. Moncure and Mr. Lynch, but that's one of the biggest ones I would say is education.
Thank you.
I would echo much of what was said by Dr. Wilkins. I have a colleague who I trained under, Dr. Clive Callender, who's devoted his entire life, MOTEP, to educating underrepresented communities about organ donation. And I think that everyone should be on the list. Everyone should know about organ donation and what its potential impact is for our communities and for our individuals that are underrepresented, period. I have not met, I've been doing this for a long time. Dr. Wilkins and I were in fellowship together at University of Maryland Shock Trauma, 1993. I've been doing this for a long time. I've not met a family who's actually gone through the organ donation process and regretted it. I've met families who have regretted not doing it and not providing help to some other individuals, something good that could become of that. And I think that's something that we need to make sure that our underrepresented organ donor families are able to kind of talk to churches and to groups of individuals that are potential donors in the future, so that they realize that there's not this a lot of stigma, a lot of the myths that are not true. And I would also echo that centers, and I know that we're getting, Jake, you're heading up a committee that we're looking at diversity, equity, and inclusion in our healthcare and of these individuals. And there are things that we need to make sure that everyone gets an opportunity, that everyone knows about their potential options as far as management. That, again, we pointed out the disparity. If you are getting renal dialysis versus you get a kidney transplant, your life is much different. We've got to know about these things.
Absolutely. Mr. Lynch.
I'm not sure how much more to add to that. But I will say, as I was listening to both of the physicians talking, I thought about that moment in time when I sat in on that meeting a number of years back, and I wanted to challenge the center about being so short-sighted when they evaluated patients as to whether or not they would be good recipients and caretakers of organs. And that particular transplant program and hospital put in a satellite center. So I think the closer you are to the source of what you're discussing, your understanding gets better. And as I think back, I was trying to find in my records what from that zip code, where that center is, how has the level of acceptance of donation, is there a correlation between those 2 points? I believe it is, but I can't prove that at this moment. So I think when you get down in the weeds, I can't think of the author that is the caretaker, but make no decisions about me without me. So if you're going to talk about me, at least let me be in the room.
I think by that, Mr. Lynch, thank you for what you did, and that we need to do that across the nation. By that center putting their resources in that community, it shows that they care. And so that has to make a difference just off the bat.
Sure.
And as I would say, Dr. Moncure, you've heard me say it before, people want to know how much you care before they care how much you know.
Absolutely.
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 I think you gentlemen kind of beat us to the last punch, if you will. Like, what are your final thoughts? I don't know if you can go any deeper than that or expand upon it, but
I have 3 requests.
Okay. Oh,
3 requests.
I like that.
So my one request is that, number one, if you are not an organ, eye, and tissue donor, sign up today. If you do sign up, and if you are a donor, the second thing is not only do you have to sign up to be an organ, eye, and tissue donor, you have to have that conversation with your family. Because if you get in that position when you are going to be an organ donor, you will not be able to converse with your family to let them know at that time what your thoughts are. Sign up to be an organ, eye, and tissue donor. Number 2, have the conversation with your family. And number 3, get your information from reliable sources. We don't want you talking to Dr. Google or crazy Uncle Joe. You can go to the Midwest Transplant Network, which is an organ procurement organization that serves your area. You can go to Gift of Hope. You can go to the National Donate Life, but get your education. So sign up to be a donor, talk to your family, and get informed.
Drop the mic.
If we did those 3 things, we'd be out of business from that standpoint. We'd be in good shape. We'd be in good shape.
That would be okay. That would be okay.
Well, thank you, Dr. Wilkins, for bringing the collective amen to the group. Gentlemen, I want to thank you again for your time, taking time to speak to our community about organ donation, its power, softening the perceptions of it, and helping our understanding of it. And thank you, everyone, for watching this. We hope this was beneficial to you. And of course, as Dr. Wilkins advised, we would ask that you would follow Dr. Wilkins' steps there. Those are steps that are coming from 3 men who are wise in this area and are exceptionally experienced in this area. So thank you again for your time. On behalf of Russell Anderson and University Health, we just want to wish you the best and have a great day.